Welcome to this week's discussion on fatigue. Here are the learning outcomes. Define fatigue. Classify the various types of fatigue. List the various diagnostic triads. Describe the key features of each of the diseases covered in the diagnostic triads. Review the labs mentioned and then review the significance of the physical signs mentioned directly or indirectly. Definition. Fatigue is defined as the subjective feeling of weakness, tiredness, or lack of energy. Our index patient is Maria Sikalot, the 38-year-old wife of Brian, the mother of the 3 children, Zoe, Chloe, and Flo. Now, there are various types of fatigue. The classifications I'm going to use is physiological fatigue. Examples: if you haven't slept well for a couple of days, you get up in the morning, you feel tired. Overuse of alcohol or recreational drugs or prescription drugs can cause fatigue, or lack of exercise. Then there is psychological fatigue. If you are depressed, you're more likely to be fatigued. And then there are more than 100 causes of pathological fatigue. Under the pathological fatigue, I've given you here about a dozen of them. The majority of them are endocrine. So if you can think of an endocrine disease, more likely it is going to cause fatigue. So in here would be Conn's disease, hypothyroidism, otherwise known as myxedema, Addison's parathyroid disease, whether it be hypo or hyperparathyroidism, diabetes, Cushing's disease or syndrome. And then there are the various organ failures: congestive heart failure, liver failure, chronic renal failure. Then there are the anemias, the infections, and malignancies could also cause this. So there are a number of these causes. Now, you're going to encounter 2 main types of fatigue in the primary care setting: either pathological fatigue or psychological fatigue. And though I will go through 4 distinct reasons or differences between pathological and psychological, please remember that pathological causes of fatigue can result in psychological fatigue and vice versa. If you've been chronically depressed, a cause of psychological fatigue, you could then develop over the next couple of years a real physical disorder. So pathological fatigue, the duration is usually less than 6 months. In pathological fatigue, the ability to do things is markedly affected. The fatigue is worse in the evenings, but better in the mornings after a good night's sleep. And the disease over the next couple of months is progressive. 3 months ago, if we were to measure your energy level as a measure of fatigue, it might have been at 7. 2 months ago, it increased to 8. A month ago, it's 9, and this month it's the worst you've ever been fatigued. You could barely get out of bed because of the fatigue. Psychological fatigue, on the other hand, usually lasts longer than 6 months. It affects the desire, not the ability. So you have the energy to get out of your room if the house was on fire, but do I really want to go to work today? No. So it affects the desire rather than the ability. Psychological fatigue tends to be worse in the mornings and better in the evenings as you get up and you force yourself to do stuff, to go to the gym. You feel better in the evenings. I mean, in the evenings. The course of psychological fatigue fluctuating. Some days you're good, some days you're not good. Last week I had a great week. This week it started off bad on the Sunday, and it's just getting worse. But based on my previous experience, it's going to lift by the weekend, and then it's going to go up and down for beyond 6 months. Here is a statement that is true. The longer a person is fatigued, the greater is the chance of a psychological problem being present. That's a general statement. But within that general statement, that is probably 70 to 80% true. Some patients who have had their problems longer than 6 months, maybe a year, maybe two, depending on whether the nature of the disease is insidious, it could take years before the classic manifestations then present themselves. And I'm thinking specifically of a patient who, at age 24, had an autoimmune disease called Hashimoto's thyroiditis affect her thyroid gland. But the classic features of myxedema did not present until 10 years later. So here is one of my favorite gravestone epitaphs. This is the gravestone of a hypochondriac who died. I told you I was sick. The lesson here is, even though you might have diagnosed this patient previously a year or two ago, they have the same fatigue in which you've previously done CBC, CMP, urinalysis, thyroid function test, screening for autoimmune disorders, and they all came back negative. Every time they come back and you're doing a review, whether it be a 3-month review or a 6-month review, you're going to go through the same questions looking for, is something likely to have changed from last year or 6 months ago to today? So you're looking for the same red flags that we are going to be discussing shortly. Have you lost any weight? Is there any blood in your sputum or your stool or your urine? Are there any strange lumps and bumps in your neck, in your armpit, in your groin? And you're screening for the 20 odd diseases that we will be talking about shortly. So bear that in mind. Any questions at this stage? If not, let's begin what is likely to be a frustrating set of lectures. It's frustrating for both people, both the patient who complains of fatigue and the doctor who has to go through uh, a long list of possible diseases to see which of these is likely the patient having, and then having ruled that out, go through the same old process 3 to 6 months later when you do your review, and repeat that over and over again without being exhausted yourself. So having said that, the first red flag situation that is associated with fatigue is unexplained weight loss. Unexplained weight loss is defined as you've lost 10% or more of your weight in the last year or so. So if a patient over the last couple of months has lost 30 pounds and they've dropped down to from 180 to 150, that is significant for you to view as a red flag situation. So what are these three major common or important causes of fatigue and weight loss that we're going to look at? Number one is Graves' disease. We have covered Graves' disease previously when we looked at Graves' disease being defined as excess thyroxine. The most common cause of Graves' disease is an autoimmune disorder in which the body produces antibodies against the thyroid stimulating hormone receptors found in the thyroid gland. And instead of having an inhibitory effect or destroying the receptor, it actually stimulates the TSH receptor, behaves as if it was TSH, and then you have an excess production of T3, T4. Clinical picture: in addition to the fatigue, there's going to be bilateral exophthalmos, a diffuse goiter, hypertension, fine tremor, especially of the extended hands, and tachycardia. Plus an increase in the metabolic activity. So there's going to be increased anxiousness. There's going to be increased passage of loose stool as opposed to constipation, and other features of an increased metabolic activity. Labs T3, T4 will be raised, and concomitantly your TSH is going to be lower than normal. And as I said previously when we had discussed this, refer to an endocrinologist, not co-manage. Refer to an endocrinologist who will want to diagnose Graves' disease and decided whether to cut, surgery, burn, use radioactive iodine to burn out most of the thyroid gland, or poison using specific drugs like thiuracil and others to then stop the production of thyroid hormone. Addison's disease, which is otherwise known as hypoadrenalism, is defined as chronic adrenal insufficiency. This is caused by destruction of the adrenal cortex, not the medulla. In America, the most common cause of Addison's disease is an autoimmune disorder. In the rest of the world, tuberculosis. Extrapulmonary TB affecting the adrenal cortex is the most common cause of Addison's disease in the rest of the world. Clinical picture: in addition to the fatigue, there's going to be weakness. There's going to be postural hypotension. They move from a lying or sitting position and they stand up suddenly. The blood pressure will drop more than 10 millimeters of mercury. And there's going to be increased skin pigmentation, especially in the skin creases. Labs at the primary care level that are diagnostic is when you order the CMP, you will have a low serum sodium and a high potassium, hyponatremia and hyperkalemia. Remember, Addison's disease is not only going to affect the secretion of steroids, but is also going to affect the production of aldosterone, and aldosterone acts on the the distal convoluted tubules, the principal cells, to cause reabsorption of sodium in exchange for potassium. If you lose aldosterone in Addison's disease, then you lose the sodium in the urine and you have an excess of potassium in your blood. Refer these patients to the hospital because these patients can decompensate within a 24 to 48 hour period if they are stressed and they don't have the stress hormones to deal with this, and they can go into a type of shock-like situation. In the hospital, under the guidance of the endocrinologist, they're going to order serum cortisol at the appropriate time of the day or night, and we talked about this before. They're going to then inject the patient with ACTH, synthetic ACTH. And if you were to inject ACTH, adrenocorticotropic hormone, what should happen is that it increases the cortisol level in a normal patient. In a patient whose adrenal cortex has been destroyed by the autoimmune process, you give them an injection of ACTH, nothing happens to the low level of cortisol. So cortisol remains low even after ACTH injection. The endocrinologist is then going to manage this patient by replacing the steroid loss, by replacing the lack of aldosterone, and by replacing the loss of your androgen. So this patient would be on lifelong um, corticosteroids, uh, aldosterone, and testosterone if this is a male. If this is a female, you replace the testosterone with the appropriate female hormone, usually in the form of the contraceptive pill. Another cause of fatigue associated with unexplained weight loss, big red flag, is cancer. Cancer is defined as the presence of a malignant tumor. The cause of the weight loss is excess secretion of tumor necrosis factor, in addition to protein mobilization factor and lipid mobilization factor. Because remember, cancers by and large, and you learned this in trimester 2, have something called the Warburg effect. In the Warburg effect, cancers are going to depend on glucose being broken down in the process known as glycolysis to produce net 2 ATP rather than wait until the pyruvate gets into the Krebs cycle, then you can get the equivalent of more ATP coming out from the Krebs cycle. It preferentially says, I don't want to waste my time going through the Krebs cycle to get more energy. I'm just going to burn glucose and get my 2 ATP every time a molecule of glucose passes through the glycolytic pathway. What happens is that all of your glycogen stores in your skeletal muscle and your liver will be burnt up easily, and within the next couple of days, it's going to start mobilizing the fat through the process of fatty acid degradation to then produce ketone body. So you then lose subcutaneous fat, and then you've lost all your subcutaneous fat. The protein mobilization factor is going to stimulate the proteins to break down, and both breakdown of fats to give you new glucose and breaks down of proteins to give you new glucose. You know that process that you covered with Dr. Shaw in trimester 1 and trimester 2, gluconeogenesis, where they make new glucose out of non-glucose material, and this is what results in this severe wasting picture here that is called cachexia. The clinical picture in cancer depends on what and where the tumor is. So you're going to get fatigue. You can get headaches that are worse in the morning, which tells you possibility of a space-occupying tumor. If you present with hemoptysis, possibility, especially if you're a smoker, lung cancer, but you could be a non-smoker and still have lung cancer. So hemoptysis, lung cancer. Hematuria, renal or bladder cancers. Nocturnal back pain, pain that wakes you up at night. Possibility of a primary malignancy of your bone, multiple myeloma, or metastases from some occult neoplasia. Hematochezia, bright red blood in the stool, regardless of your age, is a red flag to say this could be colorectal cancer. It is more likely that you have hemorrhoids, but because it's a red flag, I'm sending you off to the specialist for them to do a colonoscopy. Bloating. Bloating, especially in a postmenopausal woman, is probably one of the earlier signs of ovarian cancer. Postmenopausal bleeding, again, a sign of cancer of the uterus, or if you find any abnormal mass in the neck, in the armpit, in the abdomen, in the groin, anywhere else in the body, and you've lost weight and you're fatigued, make the diagnosis of cancer, refer the patient to the appropriate specialist. The labs obviously will be dictated by where the problem is. So, morning headaches that are worse in the morning associate maybe with blurred vision in one eye, changes in personality or balance. A CT scan or MRI of the brain is indicative. Hemoptysis, you need to do a chest X-ray. Hematuria, um, CT scan of the abdomen looking for cancerous mass in the kidney or in the bladder, etc., etc. So management depends on where you think the cancer could be. If not, you send the patient to a medical doctor, or if you have a good relationship with an oncologist, you send the patient off to the oncologist, who is going to then has his own or her own protocol for looking at where, if this is cancer, where could it be. They might order tumor markers in the blood or in the urine, or they may do specific special exams. Any questions? As I've said before, even though we've just covered 3 causes of fatigue and weight loss, these are not the only ones. The next diagnostic triad is weight gain. Fatigue with weight gain, and the patient says, Doc, I haven't changed the amount of food. My appetite is still normal, but I'm still putting on weight every month when I weigh myself. Myxedema is one of the common causes. We've done this before, but it's good to repeat this because repetition is good for the chiropractic soul. Myxedema is a situation where you have low thyroid levels in the adult. The commonest cause in the United States is Hashimoto's thyroiditis, and an uncommon cause would be a non-secreting pituitary adenoma, which destroys the cells in the anterior lobe of the pituitary gland, which produces TSH. Clinical picture would be fatigue, constipation, weight gain, a voice that gets hoarser and hoarser as the month goes by, Waltman sign, which is slow to relax deep tendon reflexes, and edema. Initially, the edema is pitting, but remember, this is not just fluid. This is fluid caused by the deposition of myxomatous material out in the interstitial area, and that protein material attracts water, and then you have puffiness in the face, loss of the outer third of the eyebrows. And remember what I said to you before. One of the more common presentations early in a patient with myxedema is carpal tunnel syndrome. That myxomatous fluid mass is going to be deposited in one of the carpal tunnels. It's going to compress the delicate median nerve, and it may present with carpal tunnel syndrome symptoms long before the full-blown picture of myxedema manifests itself. So if you were to diagnose a patient having carpal tunnel syndrome because of the complaint of pain in the thumb and index or middle finger on the same hand, make sure that before you submit the patient to conservative care from a chiropractic perspective, you have ruled out there is no thyroid dysfunction. So please remember that from a musculoskeletal perspective. Don't forget you could have a medical problem of an endocrine nature resulting in a MSK problem. Labs obviously are going to show your decreased T3, T4, and the high TSH if this is Hashimoto's thyroiditis. If this is Hashimoto's thyroiditis, there would also be the presence of antibodies against the thyroglobulin molecule or antibodies against the thyroid peroxidase enzyme, which is the enzyme that will take in iodine and combine it with tyrosine to form the first step in the process of making thyroid hormone T4. Co-managed with an endocrinologist. The next cause of fatigue and weight gain is Cushing's disease or syndrome. Remember, the other name for Cushing's disease or syndrome is hypercortisolism because it is due to increased cortisol in the blood. It could either be due to a secreting benign tumor in the pituitary gland in the head that produces excess ACTH, and the excess ACTH is going to stimulate the zona glomerulosa. Zona fasciculata and zona reticularis to produce excess cortisol and excess androgens. Less common, it could be a benign tumor, or not confine it only to benign tumors, because malignant tumors of the adrenal cortex could also secrete excess amounts of cortisol. So adrenal tumors arising from the zona fasciculata, or it could be the fact that the patient has an autoimmune disorder or chronic arthritis, and the rheumatologist has put the patient on large doses of steroids in order to suppress the body's inflammatory attack on their own tissue. That situation where the excess cortisol is coming from the adrenal gland tumor or exogenous from prescribed steroids, that is called Cushing's syndrome as opposed to Cushing's disease, which is a pituitary problem. Clinical picture review: fatigue, moon face, buffalo hump, abdominal stria that are purple, obesity, and hypertension. Labs: ACTH is going to be increased in the pituitary problem, otherwise known as Cushing's disease. It is not going to be raised in Cushing's syndrome. In fact, it's going to be lower than normal in Cushing's syndrome because the negative feedback loop is still intact, and a CT scan of the abdomen is going to show you that the problem is coming from the adrenal gland. A CT scan of the skull is going to confirm your suspicion that this is pituitary adenoma, Cushing's disease. Co-manage with an endocrinologist. And the other condition we've also covered before, obstructive sleep apnea. This is sleep disturbance associated with upper airway collapse, seen more commonly in overweight men. Classic picture of OSA, obstructive sleep apnea: fatigue, overweight, excessive daytime somnolence. They fall asleep at the job, snoring, interrupted by spells of apnea, and you have a stop bang score of greater than 5. Remember, I had you learn what the STOP, BA, and G acronym means in this score. Diagnosis is confirmed by referring the patient to a sleep lab. They would videotape the patient during the night. They would have electrodes monitoring the brain activity, and they would have pulse oximeter monitoring the oxygen saturation, and another instrument monitoring the respiratory rate. Refer to a sleep specialist. You and I, as primary care physicians, would advise the patient, if the patient is overweight, to lose some weight. And remember, we talked about previously a newfangled surgical implant device that is implanted underneath the tongue attached to the muscles that are inserted into the tongue and the hyoid bone, and it's going to be triggered by an electrical device that prevents the tongue from relaxing and falling back into the oropharynx. Any questions? Let's look at fatigue associated with bone pain. These are all red flag situations so far. Weight loss, weight gain, bone pain. Bone pain in a patient with fatigue. You got to think of the possibility of bone metastases. Bone metastases are defined as secondary bone cancer, secondary cancer in bone. And this is due to widespread cancer. If it's in a male, the most common cause of bone metastases would be from prostate cancer. In a female, it would be breast cancer. It could be lung cancer in both male or females, or colorectal carcinoma in both males and females. Clinical picture would be fatigue, bone pain, which classically is worse at night. And unlike the benign tumor that you've learned with Dr. Budalia, osteoid osteoma, in which they have nocturnal bone pain, which is better with taking NSAIDs, whether it be aspirin, ibuprofen, or Aleve. Normally, the bone pain that is associated with secondary spread to the bone of cancer is not relieved by taking NSAIDs. Or the patient could suffer from a pathological fracture. This 74-year-old person went to a class reunion. One of his colleagues, who weighed a little more than he did, gave him a huge, big bear hug and broke his a bone in the forearm. Labs, you're going to order a comprehensive metabolic panel. The alkaline phosphatase is going to be elevated, and so will be the serum calcium. You would be obviously advised to confirm that there is a bone fracture if there was a pathological fracture, and you take an x-ray. Refer the patient to an orthopedic surgeon. They will know what to do. They will look for possibility of bone metastases. They may take a CT scan of the entire body, which is relatively a good screening tool, but a much better tool is ordering a PET scan, because the PET scan is going to pick up areas of hyperactivity, and in a situation where the patient has a history of prostate cancer, if it's a man, or breast carcinoma sometime in the past, and now they present with bone pain that is worse at night, you're looking for these hypermetabolic masses in your PET scan. Multiple myeloma is a primary malignant bone disease. It is the most common primary bone malignancy of all ages. Osteosarcoma is the second most common, but it is the most common in children and teenagers. Multiple myeloma, the malignancy affects a particular cell in the bone marrow in multiple sites in the body, and it's the plasma cells. The actual cause of multiple myeloma is unknown. There are a number of situations where an uncle in the family might have had this. Your grandfather on the same side of the family might have had this. And in those situations, it would be worthwhile having the patient and the family tested for genetic markers, looking for specific mutated genes that are associated with familial multiple myeloma. The classic picture would be nocturnal bone pain, pain in the bone, whether it be in the back or in the head or in one of the bones in the extremities, that is not relieved by, is worse at night and not relieved by NSAIDs. An uncommon presentation, but classic presentation of multiple myeloma is recurrent infections. And remember, the reason for this is a malignancy in plasma cells. Plasma cells are B cells that have matured, and they are the function of your plasma cells is to make immunoglobulins. If you have a malignancy in these plasma cells, you are going to be producing tons and tons of poorly formed, dysfunctional immunoglobulins, especially of the IgG type. And therefore, even though you have a hyperglobulinemia, the immunoglobulins that are produced are not functioning properly, and therefore you're going to have a decrease in your immune system and be prone to bacterial and viral infections more commonly. Labs, Bence-Jones proteins will be present in the urine. Remember, that's a separate urine test. It is not included in your standard routine urinalysis. There's an M spike. The serum is sent off to the lab for electrophoresis. There is a marked increase in your gamma globulins, and that results in what is known as the M spike. The M spike is for myeloma, not IgM. When you dig deeper in the serum electrophoresis, you will find it's not the IgM that is highly raised, it's the IgG portion of your immunoglobulins that are markedly elevated. These would have all been triggered by your ordering a comprehensive metabolic panel. And the comprehensive metabolic panel will show a number of things. One, um, a reverse albumin globulin ratio. That is characteristic of multiple myeloma. Because multiple myeloma is going to cause multiple lytic lesions in bones all over the body, the skull, the spine, the ribs, the long bones, the flat bones of the shoulder girdle. Lytic lesions will destroy bone, and therefore they would dump uh, calcium in excess into the blood. So in addition to the reverse albumin globulin ratio, you will have hypercalcemia. In addition, your total proteins are going to be elevated, especially your globulins as opposed to your albumins. And the last change that you are going to see in your comprehensive metabolic panel, indicative of bone problems, is an elevation in your alkaline phosphatase level. Refer these patients to either a hematologist or an oncologist for confirmation of the diagnosis, which would be biopsy and finding in the report from the histopathologist malignant plasma cells showing marked pleomorphism and hyperchromatism with bizarre nuclei and prominent nucleoli. Here is what the skull X-ray is going to show in a patient with typical multiple myeloma, multiple lytic lesions in the skull of a relatively uniform size. And this is, does anybody remember from Dr. Budalia's lectures, what appearance is this? Yep, you are correct. This is the raindrop appearance of the skull. This is what multiple myeloma looks like in the long bones. Here's one classic long bone. Here's an atypical long bone, your clavicle, and then this flat bone here, irregular flat bone. The scapula, the appearance of the lytic lesions is moth-eaten in description. It could occur in the bodies of the vertebra, and here is one that has eaten away the anterior border of this particular vertebra, which is L1, and has caused a collapse of the anterior margin, giving you this wedge shape compression pathological fracture. It is stated that multiple myeloma spares the pedicles, but I have seen a number of patients in my lifetime with a missing pedicle, the so-called winking owl sign, which turned out to be multiple myeloma. So even though it is said that multiple myeloma spares the pedicles, and there's a reason that Yoakum and Rowe have offered as to why the pedicles are spared, it could happen occasionally. The next cause of fatigue in this category with bone pain is hyperparathyroidism. This is the situation in which there is excess parathyroid hormone. The majority of cases is caused by a benign adenoma in one of the four parathyroid glands that are in some way related to the posterior aspect of the thyroid gland. And occasionally it might just be due to hyperplasia and not a benign tumor. The clinical picture includes fatigue, abdominal pain, bone pain, kidney stones, constipation, or nocturia. Remember, this is going to cause an elevation in your serum calcium, and you would have learned previously in pathology that if you have elevated serum calcium, otherwise known as hypercalcemia, whether this be due to bony metastases, hyperparathyroidism, sarcoidosis, milk alkaline syndrome, um, vitamin D toxicity when the patient takes excess amounts of vitamin D supplements. They will all present with the similar symptoms. And remember, there was a mnemonic that goes like this: stones, bones, groans, and moans. Excess calcium that comes out from the body causes the bones to become weak, and you're going to get bone pain if they have microscopic pathological fractures. The excess calcium in the blood, when the kidney attempts to restore some semblance of homeostatic balance, is going to try and excrete some of the excess calcium in the urine. It may trigger the formation of kidney stones, which will then present with painful hematuria. Excess calcium in the blood stimulates the G cells in the stomach to produce excess amounts of gastrin. Gastrin is a hormone that is produced by the gut. That hormone stimulates the nearby parietal cells to produce excess amounts of hydrochloric acid, which will then in turn cause peptic ulcers in the stomach. The excess calcium could also cause constipation or nocturia, or may even cause the patient to be depressed. And that, in a brief nutshell, is the stones, bones, groans, and moans mnemonic associated with hypercalcemia. And the most common cause of hypercalcemia in the United States is hyperparathyroidism. So the test you're going to order is the comprehensive metabolic panel, which will show hypercalcemia. And if the hypercalcemia is related to bone problems, you might find an increase in the alkaline phosphatase levels. In addition, a separate assay should be ordered, and that will show you the increase in the parathyroid hormone levels. X-rays are going to show very specific characteristic findings like salt and pepper skull, acro-osteolysis of the distal phalanges of the fingers, rugged jersey appearance of the spine, and chondrocalcinosis. And we'll look at examples of these shortly as a review, because you have done this already in radiology. Management is co-managed with an endocrinologist. Here is the classic salt and pepper appearance of the skull. The salt are the smaller pinpoint, sometimes slightly larger than pinpoint, darker areas where uh, osteolysis is occurring. Here is acroosteolysis that is going to affect the fingertips. I'll show you a much better. Occasionally, there might be cysts in the phalanges or the metacarpal bones, and these would be called brown cysts or brown tumors. Here is the fingertips of a patient with advanced hyperparathyroidism, where the terminal phalanges, the distal part of the terminal phalanges are all destroyed. Hence the term acro, which means tip, osteo, which means bone, lysis, which means destruction. The tips of the long bones in the fingers and the toes too will be destroyed in this particular fashion. This is what the rugged jersey spine looks like, alternating bands of sclerosis and lysis and sclerosis. This is not, that's where the normal intervertebral disc is, and then you have another white band, dark band, white band, intervertebral disc, and this is what the English rugby jersey looks like, alternating patterns of white and dark, hence the rugged jersey spine appearance. And then the last one is chondrocalcinosis. Chondrocalcinosis is the pathological term for the picture that is seen here. Chondrocalcinosis means it's a condition, osis, in which there is calcium, calcine, deposited in cartilage, chondrocalcinosis. Now, here's a picture of the knee joint in a patient with hyperparathyroidism. And what you have here in this gap there, that gap is not empty. That gap is actually taken up by articular cartilage in the form of hyaline cartilage, and you have these linear calcification deposits. So the radiological finding here is linear intra-articular calcification, and that is the radiological expression of chondrocalcinosis. Chondrocalcinosis due to hyperparathyroidism is more likely to be seen in larger joints, weight-bearing joints like the knee. There are other causes of chondrocalcinosis which you would have covered in radiology, which would include things like CPPD, calcium pyrophosphate deposition disease, which could also be seen in patients with this particular radiological finding. Any questions? All right, let's look at another hub that causes fatigue, and this is fatigue related to the presence of anemia. Remember, there is the clinical appearance of anemia, then there is the morphological classification of anemia, where you're going to use lab results, and then you're going to use those lab results to then determine the etiological cause of the anemia that might have presented with fatigue, pale mucous membranes, pale painful smooth tongue, or a tongue that is beef red, and the patient may or may not have koilonychia. So let's look at anemia. Remember, anemia means lack of blood. The most common cause of an anemia is iron deficiency. Iron deficiency anemia could occur due to a number of causes. One, decreased dietary intake. Two, increased loss in the GI tract, which could be either bleeding from colorectal cancers on a chronic basis, or if you're in the tropics and you have chronic infestation with hookworm, whether it be in America, Nicata americanus, or the rest of the world, Ankylostoma duodenale, the hookworm on a chronic basis sucks blood from the inside of the intestines, and then you become iron deficient and present with symptoms and signs of an iron deficiency. Or it could be chronic bleeding from the genitourinary system that could also result in chronic blood loss. The clinical picture would be fatigue. DOE stands for dyspnea on exertion, pale mucous membranes, koilonychia, or pica. Pica means eating strange things. Children might eat dirt, looking for the iron mineral in the dirt. Um, Here's an interesting form of pica that if you see this occurring in a pregnant woman, you should think of having her blood checked for iron deficiency anemia. And the form of the pica is chewing on pieces of ice. There might be trace amounts of iron depending on where your tap drinking water is coming from. There are certain places along the coast in Florida that I'm aware of that when they draw water from the aquifer and use that to irrigate the lawns, if the water is sprinkling on your fence or on the outside of your house, you might eventually see this reddish brown stain, and that means that water has a fairly high content of iron. Um, so if iron is in trace amounts in the water, when you make ice of that, pregnant women gravitate, if they happen to have an iron deficiency anemia, um, gravitate to chewing ice as a way of getting as much iron as is possibly available to them. Koilonychia, as you remember, is the curvature of the nails, and this classically is seen in iron deficiency anemia. This is what the pale, smooth, painful tongue looks like in an iron deficiency. The mucous membranes on the inside of the lower eyelids will also be pale and washed out. Labs, you need to order a complete blood count. You need to, one, confirm that there is an anemia by looking and finding a decrease in your red blood cell count, a decrease in your hemoglobin, a decrease in your hematocrit. Those together says, yes, you have evidence, laboratory, that you have an anemia. And then you're going to look at your MCV, mean corpuscular volume, to talk about the size of the red blood cell. And then you're going to look at the MCHC to look at the color or concentration of hemoglobin. And in a patient with iron deficiency anemia, you will get a microcytic hypochromic anemia. This still needs to be confirmed, and the confirmatory test is your serum ferritin. Your serum ferritin is going to be low. Boards is going to ask you to remember what happens to your total iron binding capacity. In a patient with low iron causing iron deficiency, in which is confirmed by low serum ferritin, your total iron binding capacity will be elevated. Please remember that. Depending on the age of the patient, the cause might be different, and therefore, if I had an older patient who is eating a fair amount of food that contains a normal amount of iron, so they have beef 2-3 times a week. They have other iron containing vegetables, and the dietary intake seems to be okay, but they're still iron deficient. Before I would do anything like putting them on iron supplements, I need to find out why are they losing iron. So fecal occult blood is a good screening tool in an older person with iron deficiency anemia and fatigue. You don't have to wait until they start to lose weight to think, oh my goodness, could this be colorectal cancer? They just have fatigue, pale mucous membranes, a microcytic hypochromic anemia. I'm ordering a fecal occult blood. Fecal occult blood is present. I am sending you off to uh, not a medical doctor. I'm sending you off, if the fecal occult blood, to a gastroenterologist. But depending on the state you're living in, some gastroenterologists may not recognize you as a primary care physician, so you may have to refer the patient first to a medical doctor, uh, specifically stating that the fecal occult blood is positive, with the request to rule out colorectal carcinoma. And then the medical doctor is going to look at this and go, that's good that the chiropractor is recognizing that or I should not be treating this with iron supplements, because all we're doing is delaying the diagnosis of colorectal cancer. The other cause of an anemia that is associated with fatigue is vitamin B12 deficiency. Vitamin B12 is also known as cobalamin. There are four classic causes of B12 deficiency. One is dietary lack in patients who are strict vegans. Strict vegans who are not going to eat any dairy, any animal products, are prone to developing vitamin B12 deficiency unless they supplement their strict veganism with um, brewer's yeast or some other product that is going to give them the vitamin B12 that is necessary. Atrophic gastritis, whether this be alcohol induced, Helicobacter pylori induced, or part of an autoimmune disorder in which there are antibodies produced against the parietal cells. The parietal cells not only produce hydrochloric acid, but the parietal cells are responsible for producing intrinsic factor. And if you lack intrinsic factor, even with a good source of vitamin B12 in your diet, that B12 goes right through the system, through the terminal ileum, not absorbed there, and out into the feces. Crohn's disease, that characteristically affects the terminal ileum. Remember, one of the old-fashioned terms for Crohn's disease is terminal ileitis, because there's this chronic granulomatous non-caseous inflammation of the terminal ileum. You destroy the absorptive surface, and therefore, even though you have adequate production of intrinsic factor, adequate amounts of vitamin B12 in the diet, because you are lacking um, the absorption in the terminal ileum, you will suffer from B12 deficiency and pay the consequences. And then the last, which is the most uncommon cause of a B12 deficiency, is where you have a intestinal infestation of the longest freshwater tapeworm in the world, with the longest name, Diphyllobotrium latum, which actively competes with you for the B12 in your small bowel. Regardless of the cause of the B12 deficiency, you're going to present with fatigue, a beefy red sore tongue, and if this continues for months on ends, it can then start to damage your nervous system. It classically affects the peripheral nerves and the spinal cord to give you paresthesia or sensory ataxia, because one of the places where lack of B12 is going to have a massive effect is on the dorsal columns, in addition to the lateral columns that are going to carry your upper motor neuron axons, and you're going to get sensory ataxia with a positive Romberg sign. Labs, you're going to start off with a complete blood count. You're looking for, again, there's an anemia, low blood red blood cell count, low hemoglobin, low hematocrit, and then you look at the MCV, MCHC, and you're going to find that the MCV is elevated, giving you a macrocytic, and the MCHC is going to be normal, normochromic anemia. In the past, they would order two tests at this particular time. Methylmalonic acid and homocysteine, both of these will be elevated in B12 deficiency. And in the past, they used to use this 8-step complicated test known as Schilling's test. Both of these are of historic value these days. Today, they go straight and send the blood to the lab and ask the blood lab people to do a vitamin B12 assay, which is a specialized test. Should you think that this patient, by the symptoms and the signs, the presence of the beefy red tongue and the presence of a macrocytic normochromic anemia, I wouldn't waste time ordering methylmalonic acid, homocysteine, or Schilling's test. But you need to know those tests for the boards. I would send the patient straight to a medical doctor for the doctor to then order the B12 assay and then to determine how he wants to treat this patient, because you need to find the cause and treat the cause. If the cause is dietary lack, then you educate them as to what to do. If they're a strict vegan and they are adamant about not eating any animal products, then you say to them you need to take this B12, which is synthetic. It's not coming from any animal. It is being produced in the lab, and you need to take this on a daily basis. If this is atrophic gastritis, then there's no way to correct the lack of intrinsic factor. You give the patient monthly injections of vitamin B12. If this is Crohn's disease, again, it may require you to treat the Crohn's disease, and as that is taking time for the GI mucosa that is damaged to heal and to be restored, you will supplement their need for B12 by an injection. And if this is Diphyllobothrium latum, you confirm by finding the segments of the tapeworm in the stool, and you put the patient on an anti-parasitic medication. And the medical doctor is trained to do all of that. And then there's lead poisoning as the cause of fatigue and anemia. Lead poisoning, as you remember, is also known as plumbism. Lead poisoning is defined as having excess lead in your system. That excess lead could be due to children living in old rundown inner city apartments where they have not painted the rooms, the corridors for years, and the paint which was used 30 years ago was paint that contained lead inside, and the paint manufacturers 30 years ago would put lead in the paint in order to help the paint to dry faster. When the paint dries and it starts to flake off, children running around these apartments are going to find eventually that if they took flecks of these flaking paints, dried paints off of the wall and taste them, it would have a slight sweetish taste. And yeah, they're at home, mom and dad are working, they don't know what to do, they're going to pick at this and get lead poisoning. um, People who work in the lead soldering industry, if they don't wear the protective gear, can inhale the lead fumes. But the most common cause of lead poisoning in the United States this time, unfortunately, is lead contaminated drinking water. Dr. Rabatsky would have taught you, I hope, the A, B, C, D, E, F's of lead poisoning. A is for anemia, B is for blue gum line, just where the gum meets the teeth. C is for constipation. D is for difficult behavior. E is for emesis, vomiting. F is for foot drop. When you order your comprehensive metabolic panel, you will note that the lab will say there is presence of microcytic hypochromic anemia by the MCV being low, the MCHC being low, and they might report the presence of basophilic stippling of red blood cells. So here, I'm pointing with the cursor here, that's a large red blood cell with tiny little blue dots inside this, and that's the basophilic. Basophilic means loving blue stains of red blood cells. These are the large cells with nuclei in those. Those are not red blood cells because red blood cells are the only adult cells in the human that don't have any nuclei. Those are white blood cells, and depending on whether the granules stain red or blue or pink in between, that would be basophils, eosinophils, or neutrophils. Management of lead poisoning is referred to the hospital. These patients need to have chelation, where the doctor is going to infuse into their blood lead chelating agent, which will grab on to the lead and help it to be excreted in the urine. So that is lead poisoning. Any questions? If there are no questions, then let's look at the next hub. This is fatigue associated with an uncommon complaint. My wife says my head is getting big. And she doesn't mean that I have a big ego, doc. Every year when she goes to buy me a hat, it seems to be the wrong size. So I have to get a half size bigger every year. So need for an increased hat size associated with fatigue could be an expression of a disease known as Paget's disease of the bone. Dr. James Paget obviously did not name this disease after himself. He actually called this disease osteitis deformans because he thought it was due to some slow chronic inflammation, hence the suffix itis. And because it will cause the head to get larger, the bone to get thicker, it affects the skull bones, it affects long bones, it affects the vertebra, it affects the pelvic bones, then and causes a change in the shape, hence the term deformans. Paget's disease is defined as a metabolic bone disease of unknown origin. We have speculated in the last 20 years that's a possible slow paramyxovirus infection because they have found antibodies to paramyxoviruses in the bone biopsies, but we've not really solidified that particular hypothesis to say, yes, it's definitely caused by not only a paramyxovirus, but here's the paramyxovirus type A, B4, or whatever it is. Clinical picture, in addition to the fatigue, the head is going to be enlarged, and the deformed bone not only causes the skull, the flat bones of the skull to become thickened, it affects the bones in the base of the skull and causes narrowing of the cranial foramina. And one of the cranial foramina that is characteristically narrowed is the internal acoustic meatus, through which the facial nerve, the vestibular cochlear nerve, and the nervus intermediate is going to pass through, and narrowing of that particular internal acoustic meatus is going to cause slow decrease in the hearing, so with progressive hearing loss. And there's going to be a peculiar bowing of long bones resulting in something called a saber tibia, where the bowing is not um, from side to side, it is affecting the anterior part of the tibia, the shin. Labs that are characteristic for Paget's disease, your comprehensive metabolic panel is going to show raised alkaline phosphatase. Your serum calcium is usually going to be normal, except there's going to be a bone fracture, and this will then cause immobilization, and the patient has to spend weeks in the hospital while the pathological fracture heals. The reason for this is, if you remember that in Paget's disease of the bone, there are unending cycles of osteoclastic activity followed by osteoblastic activity. So, in some parts of the bone, there will be areas in which there's increased osteoclastic activity. The bone is being broken up. Calcium is going to be released into the bloodstream, but simultaneously, in another part, there's going to be osteoblastic activity. New bone is going to be built up, and they're going to take that increase in the serum calcium out of the blood to put back in the bone, and therefore your serum calcium, unless associated with fractures and immobilization, is relatively normal. But because there is constant activity in the bone being broken down and built up, your alkaline phosphatase is going to be elevated. And then there are going to be particular signs in the skull, in the pelvis, in the long bones, and in the spine, which we will look at shortly. The management of Paget's disease of the bone from a primary care perspective is refer the patient to the orthopedist, who will then arrange for a bone biopsy. Sent to the histopathologist, the report is going to come back areas of osteoclastic activity and areas of osteoblastic activity with a characteristic mosaic pattern of lamellar bone. And that would have been what you had needed to remember about pathology related to Paget's disease of the bone. Here is what the skull looks like. These darker areas are areas of increased osteoclastic activities. These lighter, fluffy areas around are areas of increased osteoblastic activity. And as I said, this is an unending cycle. And these whitish, fluffy lesions is what gives the characteristic description to the skull seen in patients with osteitis deformans, otherwise known as Paget's disease of the bone, and the appearance is cotton wool appearance of the skull. And you need to be able to distinguish the raindrop appearance of the skull that is seen classically in multiple myeloma from the salt and pepper appearance of the skull seen in hyperparathyroidism. Here is a third classic skull X-ray appearance, the cotton wool, and there's one more we will do when we do tertiary syphilis, because you are going to get in, or you could get a clinical scenario that it would be typical of part 3, where you get a radiograph, whether it be a radiograph of a skull, a long bone, or the spine, and then you have to choose 2 out of the following 5 choices. One is going to be about the diagnosis. One choice might be about a laboratory finding. A third possible option would be how is this patient managed. So this is your cotton wool appearance of the skull. In the pelvis, and it's only present on this side of the pelvis, the right side of the pelvis. It's not present on the left side. So the left side, this iliopectineal line, is the normal width. Over here, the iliopectineal line is thickened, and this is called the brim sign. So the brim is the pelvic brim, and the iliopectineal portion of the pelvic brim is thickened, giving you what is called the brim sign. And then there is this feature in the bone. Does anybody remember this feature in the bone where in one part of the bone there's osteoclastic activity and close by there's an area of osteoblastic activity? And if you said this is known as the blade sign or blade of grass sign, you would be correct. And then over here in the vertebral column, especially seen in the lumbar region, you have this area of osteoblastic activity surrounding the bone, with the center having some osteoclastic activity. Does anybody remember the name of this sign? It's more present in here rather than in this particular area. This one here has the classic sign that is known as a picture frame vertebra. Picture frame vertebra, classically seen in Paget's disease. Occasionally, one entire vertebra may decide to show mainly osteoblastic activity. Do you remember the name of this particular sign? And if you said ivory bone, you will be correct. Now, Paget's disease is one of 4 or 5 causes of an ivory bone appearance. You need to know the others for radiology. You just need to know that if I showed you a picture with an ivory bone and I tell you here is the blood finding, and the blood finding shows normal calcium level, raised alkaline phosphatase, and this particular x-ray, I want you to tell me this is Paget's disease of the bone, otherwise known as osteitis deformans. I don't want you to pick lymphoma, which is another cause of an ivory vertebrae, but will not give you that kind of laboratory picture. And then the second cause of increased hat size is acromegaly. Acromegaly is an endocrine problem in which there's excess production of growth hormone from a secreting pituitary adenoma after the growth plates have been fused. Growth plates usually fuse at the age of 18 in boys and at around the age of 20-21 in females. And the majority of the causes of acromegaly are associated with a growth hormone secreting pituitary adenoma. The classic picture would be your hands are broad, they're spatulate, you have a lantern shaped jaw. The hat size would increase because there's increase in this part of the skull. This is the frontal bone, and that frontal bone overgrows and is called frontal bossing. In addition to that, you're going to get headaches that are worse in the morning, and headaches that are worse in the morning that are better towards the end of the day are an early feature of a space occupying lesion in the cranium. And as this lesion in the pituitary fossa, which lies in the sella turcica, which belongs to the sphenoid bone, it damages the optic chiasma, which passes in front and above the pituitary fossa. And then the crossing, the decussating fibers in the optic chiasma are going to be destroyed, giving you a peculiar form of half blindness. And the half blindness, which occurs in both eyes, affects the temporal vision. And you get bitemporal hemianopia. It actually affects the nasal fibers from the retina, but the nasal fibers of the retina are responsible for the temporal parts of the visual field. Skull X-ray is going to show an enlargement of the sella turcica greater than 16 by 12 millimeters in measurement, and it may also show erosion of the anterior and or the posterior clinoid processes. Should you consider acromegaly as the cause of the patient's fatigue and increasing heart size, refer the patient to an endocrinologist who would then do special studies and then determine in consultation with a neurosurgeon whether this needs to be operated at this particular time, or we should just wait and see, or what. Here is the skull x-ray showing 1, 2, 3 out of the 4 features of acromegaly. Here's the first one here, an enlarging of the sella turcica, the anterior, posterior, superior, inferior dimensions are greater than the outer limits of 16 by 12 millimeters. The second feature is the enlargement of the frontal bone. This is called frontal bossing. The third feature is at the back here, a very prominent EOP, external occipital protuberance. And the fourth, which is not seen here, is the enlargement of the lower jaw, the mandible. Here is what the spatulate large hands are going to look like, and we're going to focus on the fingertips, the terminal phalanges in the fingertips. And what I need you to focus on is what is described in the radiological textbooks as arrowhead formation. I know you probably would not have learned this in radiology. There's another term for this, tufting of the terminal phalanges, the tip of the terminal phalanges. I learned this in medicine as arrowhead formation or shape of the tip of the terminal phalanges. And then the third cause of fatigue with an increase in the hat size is tertiary syphilis. The asterisk means we've done this already. We actually did this when we talked about some patients, older patients, who have tertiary syphilis may present with lightning abdominal pains. But just to remind you, because as I said before, repetition, repetition, repetition is good for the chiropractic soul. Tertiary syphilis is an expression of a chronic infection caused by the sexually transmitted organism Treponema pallidum. In addition to lightning abdominal pains, you will know that this is tertiary syphilis if you have the presence of the Argyll-Robertson pupil. Remember, the Argyll-Robertson pupil may either be bilateral or unilateral. You shine light in both eyes. The normal eye pupil will constrict. The abnormal eye, the pupil does not constrict because there's a pathology in the midbrain affecting the Edinger-Westphal nucleus, which controls the parasympathetic nervous system that controls constriction of the pupil. In addition, there might be a saber tibia. Yes, you've heard the word saber tibia before. Just in the last couple of minutes, we talked about saber tibia as a manifestation of a patient with Paget's disease of the bone. So there are two possible causes of a saber tibia, and I'll show you how they look like if you took an x-ray of both conditions of the tibia, which one is Paget's disease of the bone and which one is tertiary syphilis. Tertiary syphilis, the test you're going to order is your VDRL. This has a high sensitivity, so it's a good screening test, but it doesn't have a high specificity, and therefore you're going to have to use the fluorescent treponemal antibody absorption test. Your VDRL is an agglutination test. So here is a negative VDRL test. Here is a positive VDRL test. Should you have a positive VDRL test and a positive FDA ABS test in a patient with Argyll-Robertson pupil and an enlarged hat size and or SABR tibia. You don't have to have it, but if you have it, then yes, it's another plus in the system for you to put money down that the most likely diagnosis is tertiary syphilis. You're going to refer the patient to a neurologist. So here is what the skull looks like in a patient with tertiary syphilis. The frontal bone is markedly thickened. So is the parietal bone, and so is the occipital bone, and this will then cause an increase in the diameter or circumference of the head. This here is due to an underlying chronic inflammatory lesion called gamma. I am not aware of any specific term that is used to describe this with words. So this is not your salt and pepper appearance of hyperparathyroidism. This is not your raindrop appearance in multiple myeloma. This is not your cotton wool exudates. Sorry, not cotton wool exudates. Cotton wool appearance in Paget's disease. This is gummatous appearance of the skull. Here is what the SABR tibia looks like. And if I were to just show you this picture, you need to consider two possible differential diagnoses: tertiary syphilis or Paget's disease of the bone. Both of these conditions are going to cause an increase in the hat size. So whether the patient is having to wear a larger hat every year with this does not really help you to differentiate, is this tertiary syphilis or is this Paget's disease of the bone? What will be helpful is if you looked in the eyes and tested the pupils to see what is their reaction to light. If you find that the pupil does not on one side constrict when you shone light inside, but would constrict when you go through accommodation reflex, then you go, okay, this is more likely to be tertiary syphilis rather than Paget's disease. Here is what the X-ray looks like in tertiary syphilis. There's the anterior bowing, and that anterior bowing is due to chronic gummatous inflammation, which will then cause increased vascularity on a long-term basis, and you're going to get this thickening of the anterior border, not the posterior border, the anterior border of the tibia. This is what the normal bone tibia looks like. Here is your thickened bone with, again, the anterior bowing, otherwise known as SABR tibia. Can you see how these are different? This is one solid mass of osteoblastic or osteosclerotic activity. Over here you have the combination of osteoblastic activity with osteoclastic activity, and then on the outside rim osteoblastic activity. So when you see a combination of osteoblastic and osteolytic lesions in the same tibia, then that is going to be Paget's disease. If it is only osteoblastic or osteosclerotic activity, no osteoblastic activity, then this is tertiary syphilis. Very easy. Any questions? Yes, there are more to come. Trust me, there are more to come. So the next hub is a red flag situation, fatigue associated with fever. There are more than 50 febrile conditions that could occur with fatigue. I'm only interested in you learning these three for the time being. The first is infectious mononucleosis. There's an asterisk there. We have done this, but we have done this a long while ago. We did this originally in week 4 when we did ear, eye, nose, and throat. We talked about one of the three causes of sore throat. One of them was infectious mononucleosis, the other was tonsillitis, and the third was quinsy. Infectious mononucleosis is an acute viral infection of the reticuloendothelial system. It is caused by the Epstein-Barr virus, which is an HHV type 4, otherwise known as nothing. HHV type 4 or Epstein-Barr virus. This virus is going to be spread by mucosal contact, by kissing. If the virus was spread via the bloodstream using a mosquito vector and occurred more in tropical areas in the world, especially Africa, then the disease that is associated with the same HHV type 4 Epstein-Barr virus is going to be Burkitt's lymphoma. Other places of the world, the same virus in the bloodstream, different population. This would be Asia, and in China, the same virus is likely to cause nasopharyngeal carcinomas rather than Hodgkin's lymphoma. The clinical picture of infectious mononucleosis, otherwise known as glandular fever, sore throat, fatigue, cervical lymphadenopathy, especially in the posterior cervical triangle, and also splenomegaly. Complete blood count is going to show leukocytosis because this is an infection. The white blood cell population that is going to be markedly elevated would be the lymphocytes. So there would be a leukocytosis with lymphocytosis, and the lab may report the presence of atypical lymphocytes. These atypical lymphocytes have strange shapes to their nuclei, strange shapes to the outline. They're not round or oval. And these are lymphocytes, not monocytes, because in monocytes, the nuclei would be bean-shaped or kidney-shaped. They are not granulocytes because they have no stainable granules, either red, blue, or pink. So these are lymphocytes, but they're strange-looking ones. In pathology, if this was examined by a pathologist rather than a lab person, the pathologist would have called these downy cells. So in addition to the leukocytosis and lymphocytosis, there will be these atypical lymphocytes. And if you didn't order a particular test for infectious mononucleosis, some labs are kind enough to, in their area for comments, suggest, because of the presence of atypical lymphocytes, consider the possibility of infectious mononucleosis. Result comes back with the patient, and then you go, okay, I'm going to order the monospot. The Paul Bonnell is an older test that we used to use in my days. We no longer use them because we found a more sensitive and more specific test than the Paul Bonnell. Both of these tests are heterophile antibody tests. This is about the 6th time I'm telling you this. Heterophile antibody test. Heterophile because it uses the patient's serum and it mixes it in the Paul Bonnell test with sheep red blood cells, and in the monospot, which has now replaced the Paul Bonnell test, they use horse red blood cells. Positive monospot with atypical lymphocytes diagnosis infectious mononucleus. You could also use another serological test where we're going to test specifically for the antibodies IgM and IgG to the Epstein-Barr virus. Does anybody remember which of the two immunoglobulins, IgG or IgM, tells you that if it is positive, then you're currently the infection you're having, the sore throat you're having, is more likely to be caused by infectious mononucleosis. And if you tell me IgG, you would be wrong. It's the IgM that tells you it is current or more recent infection with the Epstein-Barr virus. If your IgG is positive, increase and not your IgM for this particular antibody test, then it tells me sometime in the past, it could have been a year ago, it could have been 10 years, 50 years ago, you were exposed to this virus as a teenager, contracted mononucleosis, didn't have any problems, but you still have evidence in the blood. The way I remember the difference between IgG and IgM is IgG is for when you've had the disease and it's a long time ago, it's long gone when you have had the disease, and IgM is more recent. Okay. Conservative care is what we're prescribing. There are no antiretroviral drugs that are used specifically against the Epstein-Barr virus at this stage. Maybe in another couple of years when they have made a definite conclusion that infectious mononucleosis, the virus, the Epstein-Barr virus, is the definitive cause for patients with Alzheimer's disease, then they'll probably start treating patients with antiretroviral drugs against the Epstein-Barr virus, or they may even go so far as to develop a RNA vaccine against the Epstein-Barr virus to prevent this from developing into Alzheimer's disease 30, 40, 50 years down the line. Right now, it's the most popular hypothesis, followed by there's something going wrong with the gut-brain axis as the etiology behind Alzheimer's disease. Conservative care should be aimed at telling the patient to, if you are fatigued, you stay home, you rest. If you have to go to school, because these are teens, do not engage in any contact sports until you are fully recovered, because the issue is that if you are not fully recovered and your spleen, which is enlarged, has not gone back to its pre-infectious normal dimensions of 1 inch thick, 3 inches wide, 4 inches long, and weighs 7 ounces, then that enlarged spleen is likely to be ruptured and you could develop a fatal intra-abdominal hemorrhage. The next cause of fatigue associated with fever would be Lyme disease. This is a chronic systemic disease that is linked to the spirochete known as Borrelia burgdorferi. It is transmitted mainly by the Isodes tick, and like the other spirochetal disease, syphilis has 3 stages in the acquired variety. There's no congenital Lyme disease that we are aware of today. Stage 1, you get the bullseye rash. Now, does anybody remember what's the proper name for the bullseye rash? Because boards may not give you the bullseye rash. The proper name, because it's a red rash, giving you it, is erythema. And the erythema is called erythema migrans, because it starts off as a red lesion in the middle, and then the next couple of days it's going to spread out to give you this redder lesion around the periphery, giving you what is known euphemistically as the bullseye rash. But there's another term that I want to introduce to you at this particular time. If it looks like a target, so this is a bullseye target, but it's not. So it looks like a bullseye target, but it's not a target. What word would you use? So think about this. Let me help you here. If it looks like a boat, Scaphus, but it's not a boat, what is it called? And if you tell me, change the us to an oid and call this scaphoid, you're on the right track. There's a similar bone in the foot. It has 6 sides. It looks like a cube, but all 6 sides are not equal. So if it is looks like a cube, but it's not a cube, what word do you use? Yeah, you call that cuboid. So if this looks like a target, but it's not a target, what are you going to call this? Yes, that's the word you use. Targetoid. So you have 3 terms for this classic lesion that is seen in approximately 50 to 75 patients with stage 1 Lyme disease. Bullseye rash, also known as erythema migrans, also known as a targetoid lesion. This will heal itself whether you get sent to a doctor, he recognizes this and puts you on oral antibiotics, doxycycline. Like the primary lesion in syphilis, the chancre, that would disappear without any treatment and reappear months later. You have stage 2 in Lyme disease, and stage 2 in Lyme disease is the neurological stage, in which you get either Bell's palsy or you can have features of meningeal irritation, meningitis. This too will resolve and go away and come back years later in the chronic systemic form, causing chronic fatigue, chronic aches and pains, especially in your joints. Lab, you're going to order the Lyme ELISA reflex. And what that means is when you send this to the lab, the Lyme ELISA is a screening test. And if the screening test is positive, it's going to reflect to them doing the Western blot test for Lyme disease. Management, you co-manage this patient with Lyme disease, especially if they are in the chronic phase, with a medical doctor with experience of dealing with hundreds of Lyme disease patients. Because we actually don't have a good handle on how best to treat patients with chronic fatigue, chronic joint pains in the tertiary phase of Lyme disease. And then the other cause of fatigue with a fever would be tuberculosis. Once again, we've done this already when we looked at the causes of either chest pain or shortness of breath. This is another chronic disease. This is now a chronic granulomatous caseous disease caused by the fastidious Mycobacterium tuberculosis bacillus. Presents usually as a secondary manifestation. There's primary TB, secondary TB. Most of the times in primary TB, there's no clinical manifestation. There might be signs of a mild cough or a cold, but usually nothing. And then years later, where your immune system has been depressed, and then the 3 Mycobacterium tuberculosis bacilli that were enclosed in a calcified nodule known as your GON complex, which is your GON focus, and your reactive regional lymphadenopathy depressed immune system, you drink a lot, you develop diabetes, you are on the run from ice because you came over from uh, Central America, under the wall or over the wall in a remote portion of um, the desert, and you're constantly looking for ice to raid your workplace. That constant barrage of negative emotional forces is going to have a deleterious effect on your immune system. Your immune system drops. You start to cough, cough, cough. You have a mild fever, chronic cough, hemoptysis, night sweats, weight loss, and you don't want to go to the hospital because they're going to ask you in the hospital for documentation. So the classic clinical picture would be fever, chronic cough, hemoptysis, night sweats, mild weight loss. And if this is more on one side of the lung than the other side, remember that tuberculosis has a propensity of picking off the apices of the lungs. That one apex is going to heal with fibrosis and scarring, is going to pull the trachea, and the trachea will be deviated towards the affected side. Labs X-rays are going to show your classic apical consolidation with cavities. The sputum is sent off to the lab um, to grow either in the Lowenstein-Jensen medium or to be stained with Zeal-Neeson for them to identify the 2 or 3 or 4 bacilli, which would make this a positive test for TB. That's the gold standard according to the CDC, a positive Zeal-Neeson stain or a positive Lowenstein-Jensen culture. The Mantoux test could be used. The Mantoux test, if when injected and bred 48 to 72 hours later, because remember the Mantoux test is an example of a type 4 hypersensitivity or delayed hypersensitivity reaction. If the induration, not the redness, the induration firm area that is raised and hard is greater than 15 millimeters, that's a positive Mantoux test, which will tell you you either have been exposed to TB in the past or you currently have TB. The quantiferon test, which has a relatively high sensitivity and specificity, is the blood test that is used. And I know Dr. Budalia said to you, this is the gold standard. It's the gold standard blood test, but it's not the gold standard for the confirmation of tuberculosis according to the CDC guidelines. If you make the diagnosis of tuberculosis, I said to you earlier in the course, you are going to refer the patient to the Department of Health. They have a particular protocol that they're going to follow. They're going to want to know exactly who were in the clinic, who saw this patient, who this patient have sat close by to in the waiting room and coughed upon, because he might have spread the TB bacilli to a healthy patient, and they need to test these patients. Any questions? The next cause of fatigue is fatigue associated with nocturia, getting up more than twice at night to pass urine. One is Conn's disease. Conn's disease, which could be due to an adrenal tumor or adrenal hyperplasia, in which the tumor secretes excess aldosterone, is also known as hyperaldosteronism. The boards is trying to get us to stop using epinomic diseases. Epinomic means specific names like Cushing's syndrome, Conn's disease, Addison's disease, and shift to a more descriptive term which actually tells you that Conn's disease is going to be associated with increased aldosterone secretion. So the alternative term for Conn's disease is hyperaldosteronism. As I said, 65% of patients with hyperaldosteronism, otherwise known as Conn's disease, it is caused by an adrenal tumor growing in the zona glomerulosa. The zona glomerulosa produces aldosterone. The zona fasciculata produces glucocorticoids. The zona reticularis produces androgens, from which we're going to get testosterone, estrogen, and progesterone. The other 35% of patients with hyperaldosteronism, you just have a generalized hyperplasia, increase in the number of cells that are found in the zona glomerulosa. The zona fasciculata and reticularis are not affected in Conn's disease. Clinical picture would be fatigue. Because of the effect of excess aldosterone, remember, aldosterone, when it is secreted normally, causes reabsorption of sodium from the urine into the blood. When you have excess, then there will be excess amount of sodium being absorbed from the urine into the blood. What comes in along with the sodium from the urine would be excess water. This will then cause increased blood volume, and the body's going to say, I need to get rid of some of this excess water, and the easiest way to get rid of this is to pee it out. So the patient is going to present with polyuria. This is going to result in an attempt to maintain the balance with polydipsia. So if you just listened and heard polyuria, polydipsia, and didn't ask about what about your appetite, you are likely to misdiagnose this as diabetes mellitus and not make the right diagnosis. They will get up at night to pass the excess urine. And because of the hypernatremia is going to cause increase in your blood pressure. So one of the classic features of Conn's disease is polyuria, polydipsia, nocturia with hypertension in a younger person. Comprehensive metabolic panel is going to give you a clue as to what the problem is. Excess aldosterone is going to cause hypernatremia, and that is going to be offset by hypokalemia. The lab that is going to be necessary when you refer this patient to an endocrinologist, what the endocrinologist is going to do is order two separate blood test assays. One is aldosterone assay, which would be high, and two, they're checking for renin levels, because there's another scenario in which aldosterone could be elevated. If your renin levels are elevated, the renin levels are going to cascade into the renin angiotensin aldosterone mechanism. And if you raise your renin levels, you're going to raise your aldosterone levels, and this will give you hypertension. And that is different from the hypertension that is related to hyperaldosteronism, in which the renin levels are going to be low, not high. So please be on the watch out for that combination of lab results: hypernatremia, hypokalemia, hyperaldosteronism, and low renin levels. The other cause of increased fatigue with nocturia, getting up more than 2 times at night to pass urine, is diabetes mellitus. This is part and parcel of the differential diagnosis of nocturia. Diabetes mellitus, whether it be any of the 5 types of diabetes, is due to an insulin deficiency. This insulin deficiency could be absolute, like in type 1, or relative, as in type 2. We're not going to talk about type 3, 4, or 5. You can go Google that and learn a little bit more about that. So we're only going to talk about type 1 and type 2 because that is what the boards will concentrate on. Type 1 is usually associated with a viral infection that affects the pancreas One of the childhood viruses that is definitively linked with acute pancreatitis is the mumps virus. Mumps, in addition to causing inflammation of your salivary glands, in particular the parotid gland, so parotitis could shift to inflame the pancreas, causing a mild acute pancreatitis, or go down further south in the male and cause orchitis and then cause subinfertility. More recently, there have been a number of cases of young adults developing type 1 diabetes a month or so after acquiring the SARS-CoV-2 virus. One of the uncommon manifestations of COVID-19 infection is damage to the beta cells in the islets of Langerhans. Diabetes type 2 occurs in older adults and is associated with obesity or overweight. As I said, we're not going to talk about gestational diabetes. We're not going to talk about Moody, and we're not going to talk about the recently described type 5 diabetes, which was actually discovered years ago in the 1950s in the West Indies. The classic picture of a patient with diabetes mellitus, whether it be type 1 or type 2, would be polyuria, polydipsia, polyphagia, and nocturia. If this were type 1 and the patient has a complication like an infection or physical or emotional stress, then that patient might develop diabetic ketoacidosis, which presents with abdominal pain and vomiting, acetone breath, and that would be requiring hospitalization. If not, then you confirm the diagnosis by ordering the CMP. In the CMP, which is a fasting blood test, will then show that the fasting blood sugar is above 126 milligrams per deciliter. Should that confirm the diagnosis of diabetes mellitus, co-manage with a medical doctor and a dietitian. And you're asking, what can a chiropractor do that would help a patient manage his diabetes mellitus better? I send you back to D.D. Palmer's first green book, written in 1906. I can't remember the exact page, but D.D. Palmer writes that, and I was taken aback by this particular paragraph. Unlike the medical fraternity, who thinks that the etiology of diabetes mellitus lies in the kidneys, and I'll tell you why right now. Patients with end-stage diabetes die from kidney failure. You do an autopsy in a patient with end-stage diabetic nephropathy. Both kidneys are scarred, they are shrunken, they spill tons of sugar, and then you have complications resulting from the hyperglycemia triggering or worsening hypertension and atherosclerosis. The medical doctors in 1906 that D.D. Palmer had access to the medical literature, the books that they used, all stated that the problem was in the kidney. D.D. Palmer writes, I think that the problem is not in the kidney but lies in the pancreas, and he tells us why. Because there's often a constant subluxation at T9, maybe T10. And from his understanding of the anatomy of the spinal cord, from studying Gray's Anatomy in the first decade of the 20th century, there was a nerve coming off of the spinal cord which went through the contributed to the formation of the greater splanchnic nerve, which comes from T5, 6, 7, 8, and 9, goes into the celiac complex ganglia, and then there's a branch that comes off from the celiac ganglia that goes to the pancreas. The Gray's Anatomy textbook would have this one nerve coming from T9 through the celiac ganglia to the pancreas, and Didi Palmer made the assumption that that nerve goes to the pancreas, and a subluxation there could cause a dysfunction in T9 thoracic spinal nerve. You remove the subluxation and the sugar is better. It was only in 1922 when Banting and Best, two physiologists working in the University of Toronto, discovered that it's not the kidney that has a problem. The problem is in the pancreas, and they had discovered insulin in dogs, that if they were to take out the entire pancreas in a dog, do a total pancreatectomy, these dogs died shortly after because they went into hypoglycemia. If they were to dry the pancreas, desiccate the pancreas, dissolve whatever it could from the pancreas. They took that solute from the dissolved pancreas and isolated a particular hormone and gave that back to the dog that they've just taken out the pancreas from. That dog did not die from hypoglycemia. That dog lived, especially if they gave insulin by injection for the rest of the dog's life. Didi Palmer had found that out ages ago. So when a couple of years ago, I had a colleague who worked here for about 5 years, and then decided he is likely to make more money going back out into private practice. He was a great teacher, but had just married. He'd just had his first child, David. Went back out into practice one day. The doc calls me and says, "Doc, help me understand this." And I said, "What, Deshay?" He says, "I just had an encounter with a patient who has been a diabetic for the past 3 years. I'm not treating his diabetes, but he came in this morning and said to me, 'You chiropractors don't have a clue what you're doing when you adjust people.'" So Dr. Deshay looked at him and said, "What exactly do you mean?" So the patient said, "Sometimes when you adjust me, I go home, I feel lightheaded. I check my blood sugar. It is about 72 milligrams per deciliter. I'm not hypoglycemic, but I took my insulin in the morning. I had my breakfast. I came and saw you at 9 o'clock. You adjusted me, and it dropped my blood sugar a half an hour later. It doesn't happen every time, so I've been watching this. When you put me flat on my stomach and you push down on my back, my upper back, that was the time that my blood sugar drops. But when you would put me on the side and you do that cracking where you push on my one shoulder in one direction, you push on my knee in the opposite direction, and I crack, it doesn't happen. So the doctor calls me to ask if I have any physiological explanation as to what is happening. And I said to him, "Do me a favor, do yourself a favor." I had the green book right there in front of me because it was a present from Dr. Shreve. And I said to him, "Go on, look at page 144 or whatever it is. And when you've read it, come back and you and I are gonna have a discussion." And he called back later in the day. We had a discussion how removal of a subluxation at T9 or T10 may affect the functioning of the pancreas. So that's your role. Your role also should be, especially if you're dealing with a patient with type 2, the patient is overweight, eating the wrong diet, is Advise him on a better diet, advise him on exercise, advise him on taking walks for more than 30 minutes every day, advise him on other ways to lose some weight, and that would be your role helping a patient to manage his diabetes better. If he is on insulin, you may want to say to him, if you find yourself feeling lightheaded, half an hour or an hour after you've had an adjustment by me, just check your sugar and see if you don't need less insulin next time. I've not heard of a similar effect on patients with oral hyperglycemic agents. This is anecdotal um, evidence, not anything else. It might actually be hearsay anecdotal. So co-manage with a medical doctor and a dietitian. The three of you, your role is to bring the HbA1c, not the fasting blood sugar. So we're going to use the HbA1c, glycosylated hemoglobin A1c, which is going to give you a measure of what the blood sugar has been doing over the last 3 months. You want it down under 7 but greater than 6. The normal HbA1c is between 5 and 6. You do not want the patient to aim to bring his blood sugar down under 6, because if he's chasing the numbers and pushing up the daily insulin, he may slip into hypoglycemic coma and not recover. You might find him in the evening, collapse there, dead, because he wanted a tighter control. So the current recommendation from the American Association of Diabetologists is to bring the HbA1c to between 6 and 7%, not below 6, not greater than 7%. Diabetes insipidus should also be considered in a patient with fatigue and nocturia. Diabetes insipidus is due to a lack of ADH, and I'm not too sure if you learned from your pathology teachers what's the difference between diabetes mellitus and diabetes insipidus. The two words mean, or terms mean, something different. The term diabetes is a Greek word to mean flowing through like a fountain. And if you imagine you go to Rome or Greece and you have a fountain sitting in the middle of the square, and there's a guy holding a pot of water, or there's a little boy peeing, and there's water constantly pouring from his genitals, that would be the picture that the Greek physicians were looking for, flowing through like a fountain. The word mellitus is the Greek word for honey. So when the word, the disease diabetes mellitus was recognized in ancient Greek times, back when Hippocrates was teaching his medical students how to differentiate between diabetes mellitus and diabetes insipidus. He had made a connection between diabetes mellitus and eating too rich food. So food was used as medicine to say, cut out this, cut out that, eat a more healthy diet. Diabetes insipidus, the urine is tasteless. The word insipid is an old English word for tasteless. If my wife were to forget to put salt in my favorite black eye and peas rice, black eye peas and rice meal, I'm going to go, oh, lovey, this is insipid, and she's familiar with the word insipid. Oh, sorry, can I bring some salt? She doesn't mind eating less salt in her diet because she's hypertensive. Uh, I, I can't eat insipid food. I have to have a little salt, a little more pepper to give it some flavor. So diabetes insipidus is flowing through like a fountain, but the urine has no taste. In fact, it is just like water. This, as I said, is due to the lack of ADH, and ADH could be due to one of two main causes. One is called central diabetes insipidus, where there's a disconnect caused by sharing head trauma. The hypothalamus is disconnected from being connected to the posterior pituitary lobe by the hypothalamic stalk. The hypothalamic stalk is a thread-like structure which passes through a tiny little hole in the fold of dura that runs between the anterior and posterior clinoid processes covering the sella turcica. That dura is called the diaphragma sella, and if you have A to P force hitting the top of your head and you push your brain backward sharply, it will cut that thin thread-like structure, disconnect the axons that are going to carry ADH, which is produced in the supraoptic and paraventricular nuclei, and it no longer is stored in the axons, the terminals of the axons in the posterior pituitary lobe. And even though ADH is still being secreted, there is no way it can get into the blood circulation. So that is central diabetes insipidus. And I could imagine soldiers involved in battles in Greece with the Spartans and with the barbarians and whoever was trying to conquer them at that particular time during the wars, um, being hit on the head, covered by a helmet with a big axe, having survived that incident, but suffering from symptoms of diabetes consequent to the head injury and being written up in the medical textbooks in Greece at that particular time. The second, less common cause of diabetes insipidus is called nephrogenic, in which there's nothing wrong with the ADH secretion from the supraoptic and paraventricular nuclei in the hypothalamus. Nothing is wrong with the release of ADH from the terminals of the axons related to these nuclei in the posterior pituitary lobe. But when the released ADH gets into the blood and goes to the kidney looking for specific receptors in the principal cells found in the collecting ducts, there are no receptors. So because of the kidney receptor insensitivity, then ADH does not have its anti-diuretic hormone effect. As a result, you're going to get fatigue, you're going to get nocturia, you're going to get polyuria, but you're not going to get polyphagia. So it looks like diabetes mellitus, or it could look like the disease that we discussed just before that, presenting with nocturia. The test is a simple one for you and I to do as primary care physicians. What we say to the patient, if we think that their polyuria, polydipsia, nocturia is related to diabetes insipidus and not diabetes mellitus, we can say to them, I want to see you early tomorrow morning. I'll come in early in the office. I want you from 6 o'clock this evening not to drink anything that is fluid. So no water, no soda pop, no juices, no tea, nothing with any fluid in there. And I want you not to pass urine, come straight out of bed, put on some clothes. I'm going to give you a glass or a clear container for you to go and pee. And when you pee, I want you to bring out the container filled with pee. I look at the pee that you bring out and it looks like plain water. You don't have the capacity, I don't have the capacity in my office to test the specific gravity, but I can just do a visual inspection. It looks like the water that was just poured out of the tap. So if you produce dilute urine after water deprivation, and it could be confirmed in the lab. You can do the same thing in the lab. They go past urine in the lab early in the morning. They measure a constant specific gravity of 1.006. Water is 1.000. This is as close to water you could get the urine at. Then you have enough proof to think this is diabetes insipidus. You then refer the patient to an endocrinologist who will then work out, is the problem in the head or is the problem in the kidney? If the problem is in the head, the treatment is very simple, especially if they can prove that there is a disconnect between the hypothalamus and the posterior pituitary lobe. There's no stalk, pituitary stalk. Then what they will find is no ADH in the blood when you do a specific ADH assay, and then they give the patient synthetic ADH, which is marketed as desmopressin. It is in a spray form, and all it requires is a puff intranasal. It goes right up into the roof of the um, nasal cavity. It gets into the blood circulation just above the cribriform plate and right into where it's needed to then get into this. You don't have to inject this patient with this transnasal administration of synthetic ADH is all that is needed. Now, if the problem is because of the kidney not having receptors that are sensitive to ADH, that's a different kind of treatment, not for uh, discussion here today. Okay, so that's the management of the third cause of fatigue with nocturia. Any questions? Sometimes the fatigue is associated with ptosis. The ptosis could be bilateral or the ptosis could be unilateral. Ptosis is defined as the drooping of the upper eyelid. So the first of these three conditions that are associated with fatigue and ptosis is a condition known as myasthenia gravis. Maya comes from myo, muscle. Asthenia has to do with weakness. And gravis means in the days a century ago where we had no clue what was the cause of this particular weakness that affects skeletal muscle, the patient would eventually die, put them in the grave. So hence the term myasthenia gravis. Myasthenia gravis is a neuromuscular junction disorder. It is an autoimmune condition, and like most other autoimmune conditions, have a tendency of affecting females more than males, and middle-aged females more than younger adult females or the elderly females. It is a type 2 hypersensitivity reaction producing blocking antibodies against the acetylcholine receptors in the neuromuscular junction alone. No other acetylcholine receptors are affected. As a result of this, you're going to get fatigue, which is worse than exertion, bilateral ptosis, diplopia, and weakness that is worse in the evenings, that is progressive if not treated properly. There's a test that you and I could use in our offices. It's called the ICE-PAC test or sign, and it involves me going to the fridge in my office kitchen, getting a glove, putting a block of ice in the glove, and then holding the ice separated by the glove on one of the eyes that are affected. Remember, this is bilateral ptosis. So you're going to ask the patient to close one eye, put the block of ice over there, hold it for approximately 2 to 3 minutes, take the block off and see what happens. When you do that, the patient's ptosis on that one side would be resolved. It's not a cure. Once the temperature warms back up in that area, the ptosis will return. Um, if you suspect this rare condition, myasthenia gravis, uh, I've never seen this in my life. There have only been 3 cases written up in the chiropractic journal over the last 40 years of a patient with myasthenia gravis diagnosed by a medical doctor on treatment, comes to see a chiropractor, removes the subluxation. 6 weeks later, the myasthenia gravis has disappeared. Um, Refer to a neurologist. You don't need to do anything else besides the ice pack sign. The neurologist could use the Tensilon test, which is the test that you're going to need to learn for boards. You've learned this already for pathology. You're going to need to remember this for part 2, part 3, and part 4. But the best test is finding antibodies against the acetylcholine receptors that has 100% specificity. Since 80% of younger adults with myasthenia gravis, so the 30 to 35-year-old female that has myasthenia gravis, 80% of the younger female patients with myasthenia gravis have an underlying thymic pathology. You're going to, or he is going to, or she, the neurologist, is going to order a chest x-ray. Out of that 80%, 15% is a benign tumor of the thymus called thymoma, and the other 65% of the 80% that have a thymic mass, the underlying pathology is simple hyperplasia, increase in the thymocytes. There's no cure currently for myasthenia gravis. We have a number of drugs that will help uh, uh, deal with the um, weakness, and we have other drugs that are going to help reduce the production of the autoantibodies to manage myasthenia gravis.
Another cause of bilateral ptosis, but in older males, is Lambert-Eaton syndrome. This is defined as a myasthenic-like disease, so it could be confused with myasthenia gravis. However, the underlying cause is a small cell lung cancer. What happens in the small cell lung cancer? The body, for some inexplicable reason, produces antibodies against the calcium gated channels that are located in the neuromuscular junction. These blocking antibodies prevent calcium from entering the terminal bouton, and therefore your vesicles that are containing acetylcholine don't migrate towards the synaptic cleft, and therefore the muscle doesn't contract properly. The clinical picture is fatigue that is better with exertion compared to myasthenia gravis, in which fatigue makes the exertion makes the fatigue worse. There's going to be bilateral ptosis, but because this is seen in lung cancer, small cell lung cancer, often associated with cigarette smoking, there may be a chronic cough. And remember, I said Lambert-Eaton syndrome affects older male smokers as opposed to myasthenia gravis, which affects middle-aged females. Lab X-ray is going to show the lung mass that is characteristic of the cancer on the chest X-ray. The other cause of ptosis, but this time it's unilateral ptosis rather than bilateral ptosis, is Horner syndrome. Horner syndrome is defined as a triad of signs that are caused by the loss of sympathetic tone. The most common cause that you need to remember for boards is a apical lung cancer known as Pancoats tumor. And if the chest x-ray shows no malignancy in the apices, then you need to consider the possibility of a cerebrovascular accident knocking out the posterior nuclei in the hypothalamus, which is the area in the hypothalamus that controls the sympathetic activity. It could be seen in carotid dissection, where you are going to damage the sympathetic nerve fibers that go around the carotid artery, in particular the internal carotid artery, or it could be seen as an uncommon presentation in cluster headaches. So, in addition to the one sided pain that comes in clusters one particular time of the day for the next couple of days or weeks, associated with running eye on that affected side, stuffy nose on the same side, then there will be drooping of the eyelid on that particular side and constriction of the pupil on the same side with the cluster headache. So the clinical picture in Horner syndrome, as I said, due to the loss of sympathetic activity, would be drooping of the upper eyelid, ptosis, anhidrosis, which means lack of sweating on that side of the face, because the sympathetic nervous system is what controls uh, activation of the sweat glands, and miosis. Miosis is the medical term for constricted pupil size. As I said, the chest x-ray is likely to show a mass in the apex of one of the lungs. Should you make the diagnosis of Horner syndrome, you should refer this patient to the neurologist, who is going to confirm it is Horner syndrome and then determine what is the cause and then take the necessary action to treat the various causes. Here is the x-ray of the patient with Horner syndrome and a Pancoats tumor. And here is the irregular solid mass that is found on the same side that the drooping of the upper eyelid and the constricted pupil were found. Any questions? If there are no questions, then let's look at three other causes that are not grouped in any of the triads we have talked about. First of these miscellaneous causes of fatigue is depression, otherwise known as the blues. Depression is currently defined as a mental illness due to low serotonin. This definition is likely to be changed in the next couple of years as they sort out, is it serotonin or is it dopamine or is it GABA? Because right now, if you support the theory that this is due to lack of serotonin, you give them drugs that will then boost the serotonin production or um, concentration in the blood, and they don't respond to these serotonin uh, drugs, then you have to think maybe this is not due to serotonin deficiency and put the patient on monoamine oxidase inhibitors, which will then boost the dopamine levels. And if this would work, then you support the hypothesis that it's dopamine that is the problem. And if that doesn't work, then you scratch your head and go, I don't know what is going on. The causes of depression include genetic predisposition, possible environmental factors, possible dietary factors, and we'll talk about uh, evidence for maybe it is related to your gut microbiota. The clinical picture is having 5 out of the 9 DSM-5 criteria, which includes sadness or loss of interest in the same 2 week period. There is a mnemonic that is in the Green Book. It's called SIGI CAPS, which will give you a way of remembering 8 of the DSM-5 criteria. The ninth is sadness. The S in the SIGI CAPS mnemonic is for sleep disturbance. So it could either be difficulty falling asleep or difficulty staying asleep. Most times in patients with depression, they have no problems falling asleep, but they wake up 2, 3 o'clock in the morning and they toss and turn and go back to bed, but around 5:30, and then the alarm rings at 6:30 and they have to get up, go get breakfast, coffee, go to work, etc. And it's a never ending cycle. So S is for sleep disturbance. I is for interest lost. They're no longer interested in doing the things that brought them joy, reading books, going to the library, playing pickleball, going line dancing, or whatever floats their boat. G is having guilt feelings. They start to blame themselves. If I only didn't do that, or if I'd only done this, this would not have happened to me. E in the SIGI CAPS mnemonic stands for energy loss. They tend to run out of energy in the evenings and they drag their butts around. SIGEC. C is for concentration loss, or the concentration is poor. They pick up a book to study. They're preparing for an exam tomorrow, and 10 minutes later, they can't concentrate on what they should be studying. SIGECA is for appetite changes. Most of the time, the appetite is increased, and then they put on weight, and then they get more depressed. And again, that's a never ending cycle. P is for psychomotor changes. Now, the most common psychomotor problem is psychomotor retardation. You can see it in the way they walk, in the way they sit, shoulders slumped down, they walk, shuffling their feet because they don't have enough energy to lift their feet off of the ground. Uncommon would be psychomotor agitation. And you're not going to recognize this unless you're aware of this. Psychomotor agitation presents as frenetic activity. They are involved in 3 committees on campus, and on a free weekend, instead of chilling at the beach, they have volunteered Habitat for Humanity. If they go to church, they are involved in ushering or in children's care, and it's the person who you least likely to expect having depression until you hear a month or two later, Johnny was found hanging from the ceiling or committed suicide by shooting himself in the head or some other way. So that is P in the SIGI CAPS, and the S is for suicidal thoughts. They may or may not say, I've actually thought of killing myself. I've actually gone to Home Depot and bought 30 meters of rope. I plan to throw it over the beams in the ceiling and hang myself, or I'm going to shoot myself, but I don't have a gun, and I'm going to join the shooting range and get some practice and then use their gun to kill myself. And as I said, the last of the DSM criteria is having sadness, and you need 5 out of the 9 DSM criteria. There's no specific lab right now that is diagnostic of depression. Some patients have depressed gamma amino butyric acid. Some patients have an increase in interleukin 10. Interleukin 10 is an anti-inflammatory agent, chemical in the body, and when this is decreased, the patient, when this is increased, the patient then suffers from depression, and therefore There's a current thought process that says depression is an inflammatory process, and we're not too sure what triggers the inflammation or where is it coming from. Then there's the thought that it is due to dopamine, and it's supported by the fact that if you put these patients on antidepressants that are of the monoamine oxidase inhibitor group, some of them get better. Treatment for a patient with depression, cognitive behavioral therapist, a referral would be great to help the patient reframe their thoughts and emotions. They might give them some exercises to do, uh, postural changes that associated with throwing your shoulders back, looking up with your head straight, smiling at yourself in the mirror. So that if you change your behavior, then you are likely to change your emotions. And if you change your emotions, it might affect your thoughts and you're no longer thinking sad thoughts. 15 years ago, there was a trial in Australia. It's called the SMILES trial. And they put patients with mild to moderate depression on a standard Mediterranean diet for 6 weeks, measured the depression on whatever scale they were using, whether it was the Beck inventory or the Zoom depressive scale or the uh, health questionnaire 9 scale, before and after, and they found patients with mild to moderate depression, you can make them feel a lot better if they eat the right foods. And the Mediterranean diet, we know it's anti-inflammatory. Deep breathing exercises, particular type of yoga breathing, which is to help them to relax and kind of balance out the imbalance in their autonomic nervous system, helps. Light therapy. We know that there's an association between depression and winter. It is called seasonal affective disorders. They have been treating these patients outside of the winter period every day, 20 minutes underneath a particular UV light frequency, and there is some success in some patients with that. And then uh, linking it with lack of sunlight in the winter, possible low vitamin D levels. Some patients respond to putting them on high doses of vitamin D supplementation. Here is the patient health questionnaire 9, and you give this to the patient, and they tick off these 9 criteria. And the 9 criteria are the DSM 5 criteria. Over the last 2 weeks, how often have you been bothered by any of the following? If it's not at all to any of these questions, it's 0. If it's several days, it's 1. If it's more than half uh, of the days in the week, 2. And if it's nearly every day, it is 3. And you go through um, loss of interest or pleasure in doing things. Number 1, feeling down, depressed, or hopeless. That's sadness. 2, 3, trouble falling or staying asleep. That is number 3. 4 is feeling tired or having little energy. 5 is a change in the appetite, whether the appetite is poor or you are overeating. 6, you're feeling bad about yourself, you're a failure for not letting your family down. 7, trouble concentrating on things. 8 is moving or speaking very slowly, or the opposite, being so fidgety or restless that you have to keep doing things and moving around more than usual. And then 9, thoughts that you're better off dead or hurting yourself in some way. They may express it as, I don't know why I'm here taking up space, breathing precious air that somebody else would actually appreciate the oxygen in the atmosphere. And these are cues that they have suicidal ideation. You only need two of these if you are busy and you don't have the time to have the patient go through all of this, or you don't have the time to go through all of these 9 questions with your patient, just the first two. Do you have a decreased interest in the things that brought you pleasure? Yeah. Do you feel down, depressed, hopeless, or sad? Yeah. You got those two. You're then going to make the conclusion that this is more likely to be depression and refer the patient off to a cognitive behavioral therapist, or sit down with the patient and look at manipulating the diet or increasing the vitamin D supplementation. Next is chronic fatigue syndrome. There's been a move in the last decade to rename chronic fatigue syndrome to call it systemic exercise intolerance disorder. It has not taken off. Chronic fatigue syndrome is defined as fatigue that is greater than 6 months without a known medical cause. So, this is one of those conditions that you're going to have to rule out the 24 conditions that we've just talked about. It's not this, it's not that, it's not this, therefore, we think it could be chronic fatigue syndrome. We don't know the actual cause of chronic fatigue syndrome. We think it's a mitochondrial problem. We think it might be related to the diet. There's been renewed interest in CSF over the last 3, 4 years because there are quite a few people who have come out after the COVID-19 infection, and they have what is called long COVID or long haulers. They are tired, they are fatigued, they have post exertional malaise, sleep is unrefreshing, they have brain fog or orthostatic intolerance, all of the classic features of chronic fatigue syndrome. And they're looking specifically because there's money now in that research. Uh, what exactly is going on? Once again, there are no labs. On an experimental basis, they're looking at identifying specific um, products that are linked to this is an outcome of good mitochondrial function. If it is decreased, then we think it is chronic fatigue syndrome. Management, uh, guided, graded exercise therapy. So, one of the things that is characteristic of patients with chronic fatigue syndrome is that they're in bed, they're incapacitated for a couple of weeks, they feel good for a couple of days, and they go, I should go to the gym. And they are going to say, okay, I'm going to just exercise 30 minutes. And after that 30-minute period of exercise, they're back in bed. They're incapacitated for another week. Um, don't let them give up on the exercise. You go, okay, you now know your limit is not more than 30 minutes. So let's start off tomorrow with 15 minutes of exercise. And if 15 minutes of exercise still causes the exercise induced post exertional malaise, let's dial this down a bit and next day do 10 minutes. And if 10 minutes is great, let's do 10 minutes for a week. And then next week, we're going to bump this up to 15 minutes. And if that is okay, the week later, let's do 20 minutes. And that is how graded exercise therapy goes. Once again, cognitive behavioral therapy is going to be helpful. There is some evidence, unlike there is no real evidence for upper cervical adjustments in the treatment of patients with depression. There is some evidence that upper cervical care, especially using the NUCA technique, is going to help some patients with chronic fatigue syndrome. Here is the what they're calling long COVID or long haulers. The proper name for this is post-acute sequelae of SARS-CoV-2. Definition: following COVID-19 infection of the lung, you get this chronic fatigue. We know that particular chronic fatigue that is associated with COVID infections is related to the coronavirus. Look at the current symptomatology: fatigue, shortness of breath, brain fog, sleep disturbance, exercise intolerance with or without anosmia. You can test a patient for the antigen or the antibodies to the COVID virus. And management, here is where it gets interesting. There's been increasing evidence that vagal nerve stimulation, either with an implant in the neck, internal or an external vagal nerve stimulator, can actually make these patients feel better for a couple of days, and it has to be repeated. I see this from a medical perspective. I go, isn't this what you chiropractors are hoping to do with an upper cervical adjustment? Stimulate the vagus nerve and have that have its beneficial effect not just on the neck but on the entire body function. Low dose naltrexone. Naltrexone is the generic term for Narcan. They have found that low dose naltrexone has powerful anti inflammatory effects, immune boosting effects, and this is an off label use of Narcan. You can't take the Narcan that you can get from the pharmacy and inhale it and then get relief. This is a special prescription compounding pharmacy type of medication. Plaxid has also been helpful to prevent the microthrombi, which are going to be all over the body. And they think that with the microthrombi, it is going to cause hypoxia on a chronic basis. Hypoxia on a chronic basis is going to affect the production of ATP in complex 5 in the mitochondria. And therefore, if you can prevent this from happening, you can prevent these patients post-COVID from developing post-acute sequelae of SARS-CoV-2, otherwise known as long COVID. The other condition that is associated with fatigue is fibromyalgia. For years, there was a debate, is this fact or is this fiction? Today, I think most people would recognize that no, we can have evidence to prove that fibromyalgia is actually a real disease rather than people who can't cope with the stresses of life. They develop aches and pains and they go to a doctor and they complain and they get sick leave and they get excused off from doing hard work at their etc. This is a syndrome that is characterized by chronic widespread musculoskeletal pain without evidence of soft tissue inflammation. The classic presentation of this would be a number of tender points, not trigger points. You press in specific places in the body. The patient, oh, that is painful, and they biopsy these until the cows have come home, and they can't find any microscopic evidence of inflammation. Therefore, this is why a lot of doctors says, no, this is some psychological problem. Problem is in your head. However, with the advent of fMRIs, functional MRIs, you can actually put two patients, one normal, one with fibromyalgia, give them a task while they are in the MRI machine, a mental task or a physical task that involves them perhaps moving their big toe or their little finger, and then see which parts of the brain are activated during the performance of this particular um, non-painful task. And then you can take that to a radiologist who is um, expert in reading fMRIs. Don't tell him which patient is normal and which patient has the fibromyalgia. And 9 out of 10 times, the well trained radiologist is going to pick out the fMRI with the patient with fibromyalgia. So we know there is a problem with the processing of information that comes up from the periphery through the spinal cord into the brain. We're not too sure what exactly is the cause of this disafferentation. The incidence of fibromyalgia is between 2 to 8% worldwide. Females are twice as affected as males. And as I said, we think it might be a problem with augmented pain and sensory processing. The ICD, there is a ICD-10 code M79-7. So the medical fraternity has finally accepted that this is a real problem. Diagnostic criteria was originally developed in 1990 and has gone through 3 iteration changes, 2010, 2016, 2020. The diagnostic criteria has gotten a little more complicated. In my days, here is what the American College of Rheumatology suggested. You have to have chronic fatigue greater than 3 months, not 6 months. It has to be widespread, both sides of the body, left side and right side. It has to be widespread above and below the navel. It has to be associated with fatigue, unrefreshing sleep, cognitive dysfunction, brain fog, I can't concentrate on, and then 11 out of 18 tender points. And these tender points are bilaterally distributed, related to the base of the skull, the upper neck, middle neck, second costochondral joint, the lateral epicondyle of the humerus, an area over the location of the rhomboid minor and major muscles or the supraspinatus muscles, the greater trochanter, upper um, gluteal regions, and medial fat pad. And you need to have 11 or more of these tender points. Remember, these are not trigger points. So when you press on these, they're not going to cause pain radiating into a predetermined pattern. Treatment. There have been studies that have just found that just listening to the patient talk and asking questions and digging deeper and showing that you're listening and you're trying to understand and believing what they're saying is of great therapeutic value. So encourage the patient to tell his or her story. What they have found also that chiropractic care, um, it doesn't, there isn't any studies to show one particular kind of chiropractic care is helpful. I read an article, um, wasn't published in a chiropractic journal. It was published by the people who do readjustment of the spine if you happen to have functional scoliosis using the Pettibon technique. If you Google Pettibon technique and fibromyalgia, they will say using the Pettibon technique, which is da 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 da, etc., is helpful for many patients suffering from fibromyalgia. Manipulation of the diet. Cut out the inflammatory foods. Eat um, foods that are going to promote healing. Exercise and Tai Chi in particular in the elderly is helpful in helping patients manage their pain and aches associated with fibromyalgia. Once again, cognitive behavioral therapy could help them to adjust their thinking and their emotions. Green LED light therapy. In some patients, 20 minutes of exposure to two green screens bombarding you with green LED light is helpful. Supplementation with vitamin D is helpful. And there's something more recently called repetitive transcranial stimulation, stimulating a part of the brain. And the part of the brain that they're actually stimulating, I mean, I saw this many, many years ago, 2002. I was a visiting professor in one of the Swedish universities. I think it's Ulm. And the dean had a particular interest in using light therapy and also using transcranial magnetic therapy. And what I found that was interesting, that they would put their magnetic electrodes over the particular part of the skull that lies directly over the motor cortex, not the sensory cortex, not in front of the frontal lobe, but that area that is Brodmann's area 4. Stimulation of the motor cortex of the brain transcranially on a repetitive basis, and there's an asterisk there, there's some information down at the bottom if you're interested, uh, is showing some good promise in the treatment of patients with fibromyalgia. Any questions? If there are no questions, we'll then go to the next section, which is a summary of the various lab tests that we mentioned as we went through. Is it this? Is it that? How do we know it's an infection? How do we know it's a cancer or thyroid problems? So, one of the labs we ordered was a complete blood count. Patients with anemia are likely to be fatigued. We need to find out what kind of anemia after we've confirmed that there is an anemia. So we're going to look at the first blood index. If the red blood count is low, if the hemoglobin is low, then you have an anemia. We then look at your MCV and your MCHC and determine is this a microcytic hyperchromic anemia? Is more likely to be iron deficiency. We can then go into order your total iron binding capacity, which would be up in iron deficiency anemia, and we order your serum ferritin, which would be low in iron deficiency. If the MCHC is high and MCV is high and your MCHC is normal, this is a macrocytic normochromic anemia. Are we dealing with folic acid deficiency or B12? And you can go and do the assay straight away. But remember, you need to remember the Schilling test from a historical perspective for boards and the use of methylmalonic acid and homocysteine. If there was a, a bacterial infection, then you look for the presence of leukocytosis and neutrophils. If it was a viral infection, like with infectious mononucleosis, then you're looking for the presence of increased lymphocytes and atypical white blood cells. You order a comprehensive metabolic panel if the patient had fatigue and nocturia or polyuria, polydipsia. You got to suspect diabetes mellitus, and you got to look at the fasting blood sugar level. If it is greater than 126 milligrams per deciliter, you have the diagnosis. If it were any of the other endocrine problems like Conn's disease or Addison's or Cushing's, you look for the levels of sodium and potassium. Hypernatremia and hypokalemia are going to go with Conn's syndrome. If there's hypercalcemia, then there's a possibility of hyperparathyroidism. If it were Cushing's, in addition to having hypernatremia and hypokalemia, because the cortisol that is produced in excess in Cushing's disease or syndrome is a glucocorticoid, you may find that the blood sugar is also elevated. Again, sticking to the um, comprehensive metabolic panel, if the patient has fatigue and is associated with edema and is a child with swollen abdomen and legs and arms, and they have this flaky paint dermatitis and a red hair, possible kwashiorkor, you can then look and see that the total proteins is going to be decreased. If the albumin globulin ratio is reversed, it's not 2 to 1, but 1 to 2, you consider the possibility of multiple myeloma. And then you are going to, with that information, order a special test of the urine looking for Bence-Jones proteins. Bence-Jones proteins is a heat test. In my days, what we used to have to do is heat the test tube half filled with urine, and when the temperature got up to around 40 degrees to 60 degrees centigrade, the clear urine became cloudy. If we then continue to raise the temperature to where the urine starts to boil, that cloudiness disappears completely. And then what happens when it cools back down and it drops from 100 to between 60 and 40, it becomes cloudy again. And if you were to leave the test tube half filled with urine on the lab bench table, um, and you come back a half an hour later and it's back to room temperature, the urine looks absolutely clear. That was the original technique described by Dr. Bence-Jones many, many years ago. This has been replaced by doing urine electrophoresis. The presence of Bence-Jones proteins is characteristic but not pathognomonic for multiple myeloma. Another special test in a patient with fatigue and edema was the echocardiogram. This is a special heart test using ultrasound. Anytime you see this wedge shape picture with a curve that is concave up at the top, this is an ultrasound. And this is a transthoracic ultrasound looking at the heart from the outside perspective. Here's your left ventricle, here's your right ventricle, here's your right atrium, here's your left atrium, and here's the bulging of perhaps the posterior leaflet of the mitral valve. And the left ventricle, as you see, is much larger than the right ventricle. This is because the left ventricular muscle is failing to contract and more blood is collecting inside the left ventricle. So the pressure inside here would be increased. It gets reflected as increased pressure in the left atrium. And what the technician is going to do is measure how much this volume is at the end of diastole. It's approximately 110 to 120 cc's of blood. And then you take another picture at the end of systole when the heart has contracted. And it usually is approximately 70 cc's that is pushed out from each normal ventricle. And you work out 70 cc's over 110 cc's, that's approximately 55 to 65%. That's the normal ejection fraction. And if it is less than 40%, then that's the definitive gold standard diagnostic criteria for heart failure. Methylmalonic acid and homocysteine levels are useful in distinguishing between folic acid deficiency and B12 deficiency. Both folic acid and B12 deficiency cause an elevation in your homocysteine, but only B12 deficiency is going to cause an increase in your methylmalonic acid. Other labs would be special labs, an injection of tensilon in a patient suspected with myasthenia gravis. Tensilon is an anticholinesterase drug. Remember, acetylcholinesterase is a normal occurring chemical in the neuromuscular junction and other places where acetylcholine is released. The excess acetylcholine that is released, that is not used up to stimulate action potential generation in the motor end plates of your neuromuscular junction, will be destroyed by this naturally occurring acetylcholinesterase enzyme. Tensilon, which is the preparatory name for edrophonium chloride, blocks the effect of acetylcholinesterase, and therefore what happens, you allow more acetylcholine to fill up inside the synaptic clefts associated with the neuromuscular junction, and this is going to temporarily relieve the weakness that is causing the bilateral ptosis. So before the injection, this is what happens, and within 10 to 15 seconds after the injection, this is what happens. This is a short-acting drug and is only used for diagnostic purposes in the past. We have a much better test because that has a higher specificity, 100% as opposed to 94, which is not bad. So tensilon test is probably used for historical purposes. Boards is likely to ask you about tensilon test. They're unlikely to give you an option. Anti-acetylcholine antibody test um, because they're not there as yet in there trying to modernize these questions that have been there for the last 30, 40 years. We talked about patients with hypo or hyperthyroidism that can present with fatigue. If you think because of the puffy eyelids, the loss of outer third of the eyebrows, or bulging eyes, that this could be either myxedema or Graves' disease, then you're going to order your thyroid function test. You look specifically at the T3, T4 result. If it is low, then that is diagnostic of myxedema. If it is high, that is diagnostic of Graves' disease. You could also concomitantly look at the TSH. Remember, there is a negative feedback loop between T3, T4, and TSH, which is produced in the pituitary gland. Therefore, if your T3, T4 is low in myxedema, your TSH is going to be high. If your T3, T4 is high in Graves' disease, it is going to be concomitantly low in Graves' disease. Schilling's test, I said before, is rarely used today. It's a multi-stage test to distinguish between pernicious anemia, which is the anemia associated with lack of intrinsic factor being released by the stomach. It's a 7-step process. As I said, historical significance. If boards puts it in one of your choices in a patient with fatigue and beefy red tongue, then Schilling test is what they're looking for. Today, it is replaced by direct measurement of your B12. Secondary, you can order the methylmalonic acid and homocysteine levels. Any questions? All right, let's finish this by looking at a review of the physical signs or tests we mentioned during this discussion on fatigue. Argyll Robertson pupil, there's an asterisk next to this. We've talked about this already. For the sake of time, All you need to remember is it's seen in tertiary syphilis. It is due to damage to the Edinger-Westphal nucleus in the midbrain. The beefy red tongue is seen in patients with B12 deficiency and or folic acid deficiency, and it will result in a increase in your MCV and normal MCHC. Low methylmalonic acid rules out that this is vitamin B12. Bilateral ptosis, ptosis which is worse in the evening and is seen more commonly in middle-aged females, most likely to be myasthenia gravis. Tensilon test would be positive. If this were an older male who smoked, developed small cell lung cancer, they would still present with bilateral ptosis, but the Tensilon test would be negative. Koilonychia is the medical word for spoon-shaped nails. This is seen classically in iron deficiency anemia, which you will confirm with a low red blood cell count, hemoglobin, and hematocrit when you order the complete blood count. Morphologically, it would show microcytic hypochromic anemia. Your TIBC is going to be raised, but your serum ferritin will be low. Loss of the outer third of the eyebrow is classic, but not pathognomonic for myxedema. It could also be seen in lepromatous leprosy. So they may give you a strange medical word, madarosis. Madarosis is the medical term for loss of the outer third of the eyebrow. It's either thin or missing completely. Myxedema is the most common cause. Lepromatous leprosy, uncommon. Order your thyroid function test. You're going to confirm that this is myxedema with low T3, T4, and a high TSH. Pale mucous membranes are likely to be seen in a patient with iron deficiency anemia, lead poisoning, folic acid deficiency, or B12 deficiency. Again, you're going to order your complete blood count and go through your MCV and your MCHC. And if this is low for both of them, you think of iron deficiency anemia. TIBC is going to be low. Ferritin is going to, TIBC is going to be high. Serum ferritin is going to be low. If these are normal and the MCV was elevated with a normal MCHC, then homocysteine and methylmalonic acid is going to help you to determine, is this folic acid deficiency or is this methylmalonic acid? So, folic acid or vitamin B12. Yeah, I'm fatigued. I need to have a rest too. Unilateral ptosis, drooping of the upper eyelid, most common cause is going to be associated with Horner syndrome if there is miosis. Um, Muscle that is responsible for holding the upper eyelid up is the levator palpebris superioris, that is under the control of the oculomotor nerve. And if you have an isolated oculomotor nerve palsy due to an intracranial mass, um, the unilateral ptosis may be associated with diplopia in a particular position, especially if you're going to ask the patient to converge, look at my finger that is 2 feet in front of you. It's now 18 inches. It's now 16 inches. It's now 12 inches. What's going to happen is in the eye that has the cranial nerve 3 palsy, the medial rectus muscle will be paralyzed in that particular situation. As you bring the finger closer to the patient's face, they would stop seeing one finger and start to see two, and that would be diplopia that is classic of cranial nerve 3 palsy. Any questions? It's time to take a long break. Next week we'll be doing urogenital problems, and trust me, it is not as exhaustive and exhausting as fatigue. Download the appropriate keywords, look it over, read the chapter, and then when we come back next week, we will start a new chapter, a new topic. Okay, bye for now.